Arrancamos os trabalhos com a Conferência Cobertura Universal de Saúde, o papel central dos cuidados de saúde primários numa perspectiva universal da saúde, com o professor Jan de Maeseneer, médico de família e referência internacional nos cuidados de saúde primários, dedicou mais de 4 décadas à prática clínica, investigação e desenvolvimento de políticas de saúde com impacto a nível europeu e global. Entre muitas funções internacionais ao longo da carreira, é diretor do Collaboration Center of Family Medicine and Primary Health Care da Universidade de Ghent e da Organização Mundial da Saúde. Professor, if you please.
Prezado público, senhores e senhoras, é um privilégio e uma honra poder compartilhar com vocês algumas ideias. O seu campo na saúde e a administração hospitalar. A minha formação em medicina familiar e atenção primária à saúde. Acredito que, dados os desafios demográficos, epidemiológicos, econômicos e sociais que enfrentamos hoje em dia, é necessário abrir um diálogo entre a atenção primária e atenção hospitalar. O objetivo da minha contribuição hoje é facilitar esse diálogo e essa cooperação. I will now continue in English. Let me start with a personal note. My wife Anita and I remember our first visit to Portugal on the 22nd of April 1974. I attended in those days an international youth conference in Lisbon. There we understood that important changes were going to happen. We returned as planned on the 24th of April to Belgium, and on the morning of the 25th we were informed that José Alfonso, with his song Grandula Villa Morena, Terra de Fraternidade, had given the sign to start the revolution. The rest is history, but for us, that event we will never forget. So that's the personal aspect. I'm going to deal with you some thoughts about universal coverage, starting from the concept and putting that into context. And of course, universal coverage is very important because it means that all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. It covers the full continuum of essential health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. And to make that happen, you need strong, efficient, and equitable health systems that are rooted in the communities they serve. Primary health care is the most effective and cost-efficient way to get there. And, of course, we have to work with all the dimensions of primary health care. We have to ensure that the needs are identified, that priorities are placed, and that there is a robust and equipped health and care workforce, and that all the sectors of society contribute to confront the environmental and socio-economic factors that affect health and well-being, including preparing for, responding to, and recovering from emergencies. And you know all that the target 3.8 of the Sustainable Development Goals is speaking about this aspect of universal health coverage with a focus on financial risk protection, access to quality healthcare services, and access to safe, effective, and affordable essential medicines and vaccines for all. And in many countries now, we are working with the concept of the six-triple aim. The six-triple aim is very important because it defines the 6 elements that we have to work on. And of course, the first is to improve the care as perceived by the individual. Then the second is to improve the health status at the population level. The third is, with the resources that deployed, realizing more value for the person needing care and support in the field of care and welfare. The fourth is ensuring that professionals in care and welfare can do their work in a good and sustainable way. The fifth is, to achieve the same for everyone, extra efforts will be need to be made for the most vulnerable in order to achieve social justice and inclusion. And the sixth one that was recently added is caring for and with the environment, advocating for environmentally sustainable, climate-resilient health systems that address the environmental drivers of health. And in our country, in Belgium, we have all agreed at the different levels on these aims. And I think more and more countries are doing, because it really sets the scene for where we should strive at. In my talk today, I want to refer to the data from the report State of the Health in the EU, the Portugal figures, and the country health profile of 2025. I'll do that with a warning. These are not figures that tell you something about what is good and what is bad. It positions a country within a broader framework, and it invites you to reflect and to think to the why question. Why do we do as we do it? And we are not there to make a judgment. We are there to learn and to make it an educational exercise, comparing where we are, how we can improve, and how can we make progress. And I think that this slide gives you the background for all this important contextualization, because you see that the share of the GDP that is used for healthcare in Portugal is 10%. It's exactly the average of the European Union. It's, by the way, also the same figure as Belgium. But of course, you are in a country with a different GDP than Belgium and than other countries. And that's why there is this challenging problem that is not something that the health sector is responsible for, but it illustrates the broader environment where we have to interpret data when we look at figures about our health system. And of course, you see consequences of this. One of the consequences is that in Portugal, that the public coverage is below the average across all categories of health expenditure. And it's easy to understand in the economic context why this is. And it is challenging to make a response to that. If you, for instance, see that in hospital care, 80%, because the orange is always the Portugal figure, the blue is the EU average, is 80% that is by public financing, whilst in the EU it's 91%. For outpatient medical care, 57% is public investment, whilst in the EU it's 77%. Pharmaceuticals, there Portugal does quite good, it's 55% compared to the 59% in Europe. And globally, it's 62% compared to the 80%. That means that there is a lot of co-payment through additional insurances, but also by out-of-the-pocket payment. But I have to put this into perspective, because what we see in the last 10 years, since 2015, is that the public spending on health has climbed 30% in real terms, outpacing the EU average. So that means also we have to look at context, we have to look at timelines. Portugal, I think, did great efforts to really invest more in from the public resources in health. And that's just to illustrate you the way that we have to look at figures in this, what I'm going to present you. And of course, when we talk about universal health coverage, access to health care is an important issue. And we all face, in all countries, and also in Portugal, the important input of social determinants of health. Let's, for instance, look at this. In Portugal, the share of households experiencing catastrophic health spending, that means that they have to spend money for health care that has an impact on their family budget because they have less than to spend for education, for food, for housing, and so on. So that's a situation we want to avoid. In Portugal, unfortunately, actually, this catastrophic health spending is more than double that in France or Spain, but also that you have to put in the broader context of the situation of this country. And just look at it as a kind of invitation to reflect on how can we do better in the future. Outpatient care accounts for almost half of the out-of-pocket expenditure in this country, and that's the other important feature, that is a lot of care is in the outpatient environment. Relatively less care, if you compare to other countries, is in the hospital sector. And you see here that 45% of the outpatient care of the out-of-the-pocket patient payment is in the outpatient medical care. 20% of the out-of-the-pocket payment by the patients is in the pharmaceuticals, and others are in long-term care and so on. So the situation is different in Europe, where you see that, the out-of-pocket spending is generally 15.5%, and mostly it goes to pharmaceuticals and to long-term care in the other countries. So it's just information to think about what could be the reasons why and how can we learn from each other to make improvements happen. Portugal also has a higher number of unmet medical and unmet dental care needs when you compare that. And the interesting point in the figure is that when you have on the one hand the rectangular boxes, that's the total self-reported unmet needs for medical examination and for medical care. And we have the little points that are more remote, and you see them over there. Yes, you see this kind of point. That indicates the situation of the people that are at risk of poverty. And just to illustrate you have to think about this in a very open way. The situation of Portugal is, of course, a problem because a lot of people don't access dental examination. But if you look at Belgium, we are relatively in the same situation. Also, a lot of people in Belgium have no access. Of course, everything has to be put in perspective. And I think that that's the interesting thing of this kind of figures. And then you have, of course, the local situation, the geographical situation. That's several times to the needs hospital service. And of course, that's the geography of this country and the distribution. And that's something you have to live with and to look at in a different way, in a more open way. Of course, all this has impact on the self-reported health as people expect this. And there are still gender and income-related inequalities in the self-reported health, and they are wider in Portugal than in the EU overall. And you see that both when you look at the gender issues, which are here, there's the difference between men and women. And the other thing is, when you look at the richest people and the poorest people, there is a huge gap. And the gap is more important than it is in the European Union, although also there you have the gender differences that are clear. But just to illustrate that also in other countries, and I take Belgium as the example, my own country, we face problems in healthy life expectancy, for instance, at the age of 25 years for men. And this is on purpose a picture from 2004, because it did not change. In 20 years, the gaps in between people with only basic education, which you see here, that at the age of 25 they have a kind of expectancy in good health of 28 years. When they have only basic training, when they have a university degree, they will have 45. So you have a kind of gap of more or less 17 years in between. And that has been the same since 2004. Although we had a lot of efforts to change the situation, we are confronted still with this continuous persisting gaps. And that brings us to the fact that, of course, when it comes to socio-economic inequalities, it's very important to understand that there is a difference between equality and equity. On the left-hand side, you see that equality means that you look at differences and you give the same input to everybody. And what is the outcome? That the inequalities persist. When you look at an equitable approach, you will make your efforts according to the needs of people so that everybody can reach and participate in the society. And that's something we learned also from the work that we did. I had the privilege to work with WHO on the report on the social determinants of health in 2008, Closing the Gap in a Generation, where the conclusion was very clear that the primary healthcare model that emphasizes locally appropriate action across the range of social determinants, where prevention and promotion are in balance with investment in curative interventions, and an emphasis of the primary level of care with adequate referral to higher levels of care, that is the strategy to focus on. And I think that all countries now are on that track but the way is long and not easy, and the ambition to close the gap between social inequalities in health in one generation will probably not materialize, but it's still an aim we strive for. And I want to just add a quote to bring us back to the interventions at the local level, at the interaction between patients and providers in the primary care system. And I quote Jane Haggerty, who illustrated the strength of primary care systems with this quote: "A mountain of evidence shows that low socioeconomic status is one of the highest risk factors in the people presenting to primary care. It is therefore possible that health systems that support and value high-quality clinician-patient relationships might give patients, most of whom are in a lower social class than their clinicians, an experience of respect, validation, and empowerment that translates into lower health inequality." And I think it's an important quote because it puts the problem also there where everything starts, in the interaction between a provider in primary care and a patient, and it emphasizes the importance of the quality of this interaction. Let's then jump into some core functions of primary healthcare services that can contribute to address and to strive for the universal health coverage. And I quote one of the definitions that we made with the expert panel on effective ways of investing in health, where we said, that primary care is the provision of universally accessible, integrated, person-centered and comprehensive health and community services provided by a team of professionals accountable for addressing a large majority of personal health needs. These are delivered in a sustained partnership with patients and informal caregivers in the context of family and community, and play a central role in the overall coordination and continuity of people's care. And there are a lot of people involved: the dentists, dietitians, general practitioners, family physicians, midwives, pharmacists, therapists, occupational therapists, and so on and so on. And in most of the countries now we see that there are efforts to bring those people in a team together, but that's not always easy. And just last week in the Lancet Primary Care, there was an interesting article that described what should we now do to redesign services delivery at primary care to promote the core functions. And they ended up, I think, with four very important key functions. That is, first of all, primary care should be the first choice for people's health needs. And that means that gatekeeping role of primary care is important. Secondly, primary care is a place where illnesses and risks can be detected and be taken into account. It is also the level where high-quality care over time, continuous care over time, should be realized by interprofessional teams with realistic services and very performant primary care packages. And last but not least, it is important that the population can be linked to advanced care when needed by referral to secondary care, and also to social resources. I think that also in Portugal there are interesting experiments in order to bring primary care and social care more close to one to another, because I think that's very important. I now want to take you on a journey that we did the last 15 years in our country, in our region, in Flanders, where we worked on a paradigm shift from disease-oriented to goal-oriented care. And just to start with a figure that comes also of a recent OECD study, very important, 2025 published, Does Healthcare Deliver?, where over 100 patients in 19 European countries and other countries have been asked, how do you experience care? And also there, and just as an illustration, and not to say it is good or it is bad, what we see is that on the scales for experiencing positive coordination, there is some room for improvement in the situation of Portugal. Also, when it comes to person-centered care, when it comes to trust in the healthcare system and to experience quality of care, there are possibilities to improve, and that's why I want to talk to you a little bit about the situation of elderly people that today face challenges of multimorbidity. And of course, when I was a student, multimorbidity was an exception. Today, it is the rule, because it's what we really see. And of course, we see that there is an increase in multimorbidity. You see patients here with 0, 1, 2, 3, 4, 5, 6, 8 problems. And according to age, you see that there is an increase in the percentage of the population that has this kind of multimorbidity problems. And the complicating factor is that you see the red line. For every age group, the number of people with multimorbidity is the highest in the lowest socioeconomic class. So you have a double challenge, multimorbidity, but also a social gradient. And that's why in 2011, when I was invited to give the James Mackenzie lecture, I took the subject multimorbidity, goal-oriented care and equity, because I was seeing in the reality of our health system that we had a problem with the implementation of the traditional chronic care approach. And this traditional approach is based on developing services. Of course, self-management support, delivery system design is important, decision support is important, clinical information systems. Your health system should be well organized in order to achieve what in the US they call productive interaction. We would say human interactions between an informed, activated patient on the one hand and a prepared, proactive team, in order to improve the outcomes of the patients, as we see here. But the first thing what we did and what we learned to each other is you have to invest in making this patient stronger and to try to make him more prepared. And so that was our first focus. We have to train and to inform patients that they have to be stronger and that they have to develop a lot of skills themselves. And that was fine. And we have a lot of successful interventions. Think about diabetes patients that are responsible for their own care, COPD patients, and this kind of things. So that was a very good approach. But when I look at this picture from this side, from here, I see something different than what you see. I see this. What do I see? All the system is working very well, but it misses the point. It misses what really matters to the patient. And I think that in primary care and in hospital, we are facing with this problem. And that's why I want to tell you a story of a patient, Bianca. Bianca is 75 years old. 15 years ago, she lost her husband. She is a patient in the practice for 15 years now. During these last 15 years, she has been through a laborious medical history. Operation for coxarthrosis with hip prosthesis, hypertension, diabetes type 2, COPD, and osteoarthritis. Moreover, there's osteoporosis. She lives independently at her home with some help from her youngest daughter, Elizabeth. I visit her regularly as family doctor, and each time she starts saying, "Doctor, you must help me." And then follows a succession of complaints and unwell feeling. Sometimes it has to do with the heart, another time with the lungs, then the hip. Each time I suggest, according to the guidelines, all sorts of examinations that did not improve her condition. Her requests become more and more explicit, and my feelings of powerlessness, insufficiency, and spite increase. Moreover, I have to cope with guidelines that are contradictory. For COPD, she sometimes needs corticosteroids, which worsens her glycemic control for diabetes. The adaptation of the medication for the blood pressure, at one time too high, at another time too low, cannot meet with her approval, as does my interest in her fast hemoglobin and lung function test results. After so many contacts, Bianca says, "Doctor, I want to tell you what really matters for me. On Tuesday and Thursday, I want to visit my friends in the neighborhood and play cards with them. On Saturday, I want to go to the supermarket with my daughter, and for the rest, I want to be left in peace. I don't want to change continually the therapy anymore, especially not having to do this and to do that." In the conversation that followed, it became clear to me how Bianca had formulated her goals for her life. And at the same time, I felt challenged how the guidelines could contribute to the achievement of Bianca's goals. I visit Bianca again with pleasure ever since. I know what she wants and how much I can merely contribute to her life. Ladies and gentlemen, do you know this patient? Yeah. This story I've already presented in all the continents, all over the world. And this patient, people recognize it, because that's the kind of people that we are working with. And if we do everything what's in the guidelines to take care of this patient, well, you have a lot of clinical tasks that you have to do as providers. You have a lot of patient tasks that the patient has to do to comply with joint protection and energy conservation and so on. The patient education program is to be involved for food care, for COPD, medication, diabetes, and so on. Referrals are needed for physical therapy, ophthalmology control, and so on. And there are 22 intakes of medications, 11 different medications. The real question, is there life apart from the disease? That's the fundamental question. And that's why we started to really think about, the question is not what's the matter with this patient, but what matters to this patient. And what matters to people, and Professor Boekstaans did research on that, is looking at functional status. People are interested to be able to function. That's for them very important. And also social participation is very important, because they want to be part of a community, they want to have contact, they want to see their grandchildren, and so on. So that means that the international classification of functioning, disability and health will become much more important for in the future than the international classification of diseases. And just a little question, who of you are familiar with the international classification of functioning? 5 in the room. Don't worry, it is always the same. In all different continents where representatives, the answer is the same. But I think there's room for improvement. Because what we do is we use this booklet, and it's fine. Since 1992, we use evidence-based medicine guidelines, and that's okay. But we need more than that. And that also, we want to change the kind of the definition that problem-oriented and the disease-oriented approach is looking at the absence of disease as the goal, as defined by the healthcare system, whilst in a goal-oriented approach, we look at the maximum desirable and achievable quality and quantity of life as defined by each individual. And I know that your country has still this vertical disease-oriented programs. We had the same plan in 2000, and I know it because I had to speak after the Portugal representative at the EU meeting in Brussels in 2010. And so it was explained, all these different programs were developed. We decided in our country, we had 12 on the program, and we only put 2 in practice, and then we stopped. Because what we saw was that these vertical disease-oriented programs, in case of multimorbidity, they create duplication in testing, in intervention. They lead to inefficient facility utilization. Sometimes people have to do 3 visits in a week for the different problems that they have. It may lead to gaps in patients with multiple comorbidities, and it may lead to inequity between patients, namely inequity by disease. And that's why actually we are training our providers, nurses, social workers, and our family doctors to shift the paradigm to goal-oriented care, to start from the life goals of the patient, and then to make sure that those life goals are central in the design of the co-design between the patient and the provider of the therapy and of the diagnosis. The next point, very important when it comes to universal health coverage as well, is that we need to have integrated records. And our government fortunately decided that the Belgian Integrated Health Record, a digital platform providing real-time access to comprehensive patient information for health professionals across different settings, will now be developed. And I'm not going into details, but what I just want to illustrate is that we are going to work with data that are what we call authentic sources, that they will be connected with the computer systems, the software systems of the providers in hospitals, the nurses, the family doctors, so that you have continuous integration of information, that you interact here as a provider with the program, that you adapt the information, and that then it will be available for other providers to deal with continuously. And so that we shift our work from working separately to working on a kind of collective framework. And that are the 15 authentic sources that we have defined. And as you can see, the life goals of the patients are there, but also the family context is there, social factors are there, medication is there, the problem is the laboratory, vaccinations, and so on. So we are actually developing that so that everybody can interact with that, and that our providers, when they see a patient, when I see a patient actually in front of me, I will see what this nurse has done, what this physiotherapist has done when I look at the record, because we work in a kind of pathway of co-creation. We use episodes of care that you are very familiar with, and I hope that family medicine already is preparing ICPC 3, the International Classification of Primary Care 3, and also, very importantly, that we use, of course, also the ICF in our approach to patients so that we can work with them. And of course, we need support, diagnostic support, so that when we interact with a patient and we prescribe an antibiotic, that the system tells us, doctor, for this patient with this renal function, you cannot prescribe this antibiotic, so that we are supported in providing quality care, and that we see continuously popping up what for this patient should be done and what is the follow-up that is needed, so that the system helps us to improve. And of course, artificial intelligence will be part of that, but my warning is this doctor described that he was an enthusiastic early adopter of AI scribes, and he then describes why he stopped. And he stopped because he saw that the documents that he had written and that AI had written for him, that was not his notes. I had not written that note. An algorithm had written it in response to sounds that I had heard, and I had approved it hurriedly at the end of a session. Now, 6 weeks later, I was reading someone else's account of consultation that I had conducted, and I couldn't recall the patient clearly enough to reconstruct what had been left out. And I think that we can do a lot with artificial intelligence, but we have to be very careful to make that happen. And it's very important that we invest in that, because patients expect us not to put always the same questions to them, because we already had the answers, or another provider had the answers to integrate that. Let me finalize, and I'm a little bit over time, but I'm going, by designing the structural organization in order to achieve universal health coverage that we actually try to put into practice. And that means that primary care works at the nano, the micro, the meso, and the macro level. And of course, at the nano level, I think it's still very important, and probably the most important level of care, because there you have the direct interaction, you have the relationship between the providers in primary care, but also the specialist providers. And of course, that's where the letter C becomes central. The commitment and the connectedness is created there. The clinical competence is used, cultural competence is there. The context is very important, comprehensive approaches are there. Complexity is embraced because it's part of the reality. Coordination is there and continuity. And of course, we have to try to reconcile the compassion with the computer, and that's a challenge. Actually, we try to organize the care in different models of cooperation. We have primary care practices that are working actually monodisciplinary way in fee-for-service in Belgium, or multidisciplinary fee-for-service. We have New Deal practices that are mixed payment, 40% capitation, 40% also for fee-for-service. And then we have the community health centers that has an integrated needs-adjusted capitation. That means that a team of nurses, physiotherapists, and family doctors have an integrated needs-adjusted sum to provide care. And of course, we will need the necessary people, and just drawing your attention to this position of Portugal. Portugal is in the group of countries with a high number of doctors and a low number of nurses. And I think there's something to reflect about that. But tomorrow, Professor Groenewegen will talk about that more in depth. We actually decided to organize all the primary care practices in primary care zones. That is 70,000 to 125,000 inhabitants. We have in Flanders 60 of these primary care zones that have a council where healthcare providers, social care providers, patients and informal caregivers are represented, and local authorities are also represented, so that we have a link with the local authorities, and we work also together with the hospital cares networks. I'm not going into detail, but we try to have both a promotive and a curative kind of approach, We do local human resources planning because the needs are different in different regions. And we put more and more emphasis on implementing population health management because a lot of diseases are not only addressable by what I would say individual approaches. And then we brought all these primary care zones together in the Flemish Institute for Primary Care so that at all levels, the nano, the micro, the meso and the macro level, we have a kind of support for the primary care. My last message is on trust. And I want to go back to the report, Does Healthcare Deliver? 107,000 patients have been interviewed, all with chronic conditions over 45 years old in 19 countries. And what came out of this interview? People are more likely to trust the healthcare system if they have a doctor they see for most of their health problems, and less likely to trust the system if they have no main point of contact. And that you see here, there's no single primary care provider. Then you see that the trust is low. When you have a doctor as primary care provider, the trust is high, and when there are others, the situation is in between. And what came out of the respondents also that those patients with chronic health conditions tend to trust the health system when they have received high quality of primary care. And that's very important. So it's the quality that they have received in primary care that determines their trust at different levels. And we see that here, that patients receiving high quality primary care report higher trust, both in the healthcare system and in the healthcare professionals. And you see the difference, the yellow or the group that have not received high quality care, and the blue are the one with high quality care. And you see that both when the trust in the health professionals in the different levels of care is higher, and also in the health system. And countries that have higher trust in the healthcare system also have higher trust in the national government. And I think that that's also an important conclusion. The way we create trust in the health system contributes also to trust in the government, and I think that's an important conclusion for us. And when we, for instance, when people think that you don't spend enough time, already your trust in the system drops with 30 percentage points. So it's important that we really spend enough time with people. So the conclusion of the report, I think it's very important that the overall conclusion is that there is a relationship between trust in the healthcare system and trust in the national government. That's quite important, also for politicians. Although you cannot establish causality based on these data, this correlation is important. Individual relationships form the basis for trust, upon which broader trust in healthcare system is built. The data demonstrate that consistent positive interactions via a single healthcare professional foster a sense of trust and reliability at the interpersonal level. Moreover, this individual experience of trust at the primary care level can significantly influence a patient's perception of the entire healthcare system, thereby shaping their overall confidence in the healthcare system's ability to deliver quality care. This spillover effect highlights the crucial role that personal interactions, the nano level and the micro level in healthcare, play in increasing the credibility and reliability of healthcare institutions, ultimately leading to a more trusted and resilient healthcare environment. Trust, like other essential aspects of the healthcare system infrastructure, must be invested in, built up and maintained. Healthcare systems and policymakers play a crucial role in fostering trust among people with acute and chronic conditions by ensuring transparent communication and accessible patient-centered care. When we link this to the importance of trust and social cohesion, the sense of belonging and democracy, and how healthcare plays a role in this, the hypothesis emerges that the quality of primary care and the quality of care in general can make a significant contribution to social connection and the sustainability of democracy. This opens new perspectives on how we view primary health care in this changing society. Let me finally say 3 slides. First of all, if you want to know more, read the book that we produced in the WHO, Implementing the Primary Healthcare Approach, a primer. Secondly, think about your health system. Most health systems are organized in this way, like a pyramid, and you have here public health, prevention screening on the basis, then you have primary care, secondary care, and tertiary care. And this is the kind of way that referrals are happening. I think that we have to think in another way. We have to put the population and the health literacy and empowerment and the integration of social care, public health and primary care on the top of our system. Prevention, health, promotion, cure care, rehabilitation and palliative. And when needed, secondary care has to support this level of care. And tertiary care has to support secondary care and so on. So it's a kind of new perception that you put on the top the population with their possibilities. And finally, it's also a matter of financing. This is the actual situation. Financing on the average of primary care amounts to 14% of the total healthcare expenditure in the OECD countries. The figures are 10-year-old, but I think that if we really want to give an answer to the challenges we are facing, that for 2026, 2050, the percentage of spending for primary care should increase from 14% to 30% of the total health expenditure. And I think that that is very important. If you want to read more, you can find the references to the book I wrote at my end of my academic career, Family Medicine and Primary Care at the Crossroads of Societal Change. And I thank you for your attention.
Thank you so much, Professor. Many things so actual. So please stay with me for a little bit. In the changes and the challenges that we saw in your presentation, let me ask you about the shift of competences. It is a very hard challenge to make, but it was already necessary. It was irreversible, facing the human resources crisis.
Yeah, I think this is a very important challenge, and the first element of answer to that is we have to start in the training of future healthcare providers, in undergraduate training. And actually, for instance, in Ghent, in the curriculum, undergraduate curriculum, every year there are activities and tasks that they have to do with students from nursing, from occupational therapy, with psychology students, with pharmacy students, and so on. So that's the first thing. You have to learn from the very beginning to work in a multidisciplinary and an interdisciplinary environment. That's very important. But the other important thing is, of course, that you have to change the attitude towards what you are doing and what your competencies are. And not seeing this as something that's closed and only for you as a nurse, I am allowed to do that and that and that, but as a competence that you have, but that you also can share with others, so that there becomes a kind of broader perspective where our primary care and hospital care providers can work, I would say, not only with shifting tasks, but also sharing competencies. Because if you shift tasks without sharing competencies, that will be a drama. So that you don't want to do that. And the other thing is you have to involve also the public. People want to see their doctor. But of course, for a follow-up of diabetes care in our community health center where I worked for 40 years, once a year, the patient for the diabetes, his or her general practitioner to talk about the diabetes type 2 when everything goes. For the rest, it will be the nurse and the diabetes educator that follow up. And of course, integration of the information and co-creation of the information creates the opportunity that as a family doctor, you can still follow what's going on, or you can have questions when things are not going or running in the right way. So you are still there to supervise, but the concrete action, the daily interaction will be done by the nurse, will be done by the diabetes educator. And it also requires a mindset change of the patient. And very often we change the structure and we change the roles, but we don't involve the patients. And of course that doesn't work because of the trust issue. So we have to work very carefully, and that's why I emphasize the importance of trust. I'm more and more convinced that if we don't look carefully at the element of trust in all the interventions we do, that we risk to lose the contact. And I think that would be a risk not only for the healthcare system, but as I demonstrated also for the society.
You showed a very important graphic there about the mono programs. That's very, very interesting because our whole system is based on mono programs and even with incentives. That's how the primary care now works. Yeah. But you also shown the map of Portugal. That's very interesting because of aging, because of the desertification, and that affects. So with multi-mobility that you very well referred, time, access, bureaucracy, incentives collides in reality with the interests of the patients.
Yeah, and I think that it's very important that we make it sure that for the patient this becomes something that is coherent and not something that I would say that's siloed in different kind of programs. Looking in your approach to what really matters to the patient, what her or his life goals are, and to formulate that in a concrete way. And we will make it a kind of an authentic source that only the patient can fill in. And I think if we would start every consultation looking at the screen where the most recent comments of the patient in what for his or for her really matter to make the life worth to be lived, that would reorientate our consultation and our interaction with the patient fundamentally and focus it on the real life goals of that person. And then we can, together with the patient, try to find out how our guidelines and our scientific basis of our interaction can be, I would say, adapted to the life goals of the patient. So that there is this, I would say, this synergy between our approach and the tasks we agree upon with the patient on the one hand and what for the patient really matters. And when working that way, I think we will be able to walk together with our patients, and that's really what our role is as care providers.
So finally, putting that all in the same equation, obviously, we have the finance aspect, so money, obviously, but all of you, the main aspect that you are referring is a revolution in the mindset. That's very hard. That is the hardest thing. But we have policymakers in this room, so we have to talk to them as well. So do you consider that the policies has to be transverse in a way that different areas as health, security, social security, education, environment have to start talking to themselves, and the policies have to join together to have an actual effect, considering the aging and One Health policy, that concept that we must have in mind?
Absolutely. I think that it is absolutely clear that you have to see that housing, education, all these factors, the environment, air pollution and so on, all these factors influence health. We talked about the social determinants, but there are also the commercial determinants. Think about food and healthy food. There are the digital determinants that sometimes lead to a digital divide. We have to look at all this, and I think that cohesion is a central element, but cohesion also at the side of the policies in order to include health when we are building new kind of neighborhoods, to see how are we going to make it proof for the future where the percentage of the population over 85 will double in the 10, 15 years to come. So we have to prepare our society, we have to prepare our environment and the mindset of people, because the society will only be served by health and by good health care when it's based on two essential things. On the one hand, scientific underpinning, but on the other hand, solidarity, cohesion, working together, because that's the only thing where politicians can build a plan for the future of societies on. And I think that there we meet with the needs of politicians, because, as I illustrated, good quality healthcare that really looks at the needs of the population will increase social cohesion, will strengthen democracy, and will create the platform where politicians can build in a democratic way the future plans for the society.
Thank you so much. Thank you. This way. Thank you.